Chapter 13 is concerned with the peripheral nervous system. The peripheral nervous system is divided into the sensory or afferent division and the motor or efferent division. The motor division is further divided into the somatic nervous system, which is your conscious part of your motor system, and your autonomic nervous system, which runs on a subconscious level. It is further divided into sympathetic division, which is fight or flight, and the parasympathetic, which is for feeding, breathing, digesting, and resting. Nerves are strictly in your peripheral nervous system. You remember the same structure in the brain would be called a tract. Our nerves are axons, made up of axons. This is a myelinated axon, and then it's surrounded by this endoneurium. They're bundled into fascicles, which are wrapped in a perineurium. They have arteries and veins packaged with them, and then you get multiple bundles of fascicles wrapped together, and they're surrounded by an epineurium. We have 12 pairs of cranial nerves associated with the brain. First is our olfactory nerve, and it's strictly sensory, comes from the sense of smell, comes off the nose. And the second is our optic nerve. It's associated with this optic chiasma. It crosses over partially. Some fibers stay on one side, some cross over. The third cranial nerve is oculomotor. You can see where it comes off the brain here. Trochlear nerve, which is cranial nerve 4, comes off the brain right here. Trigeminal comes off right here. The abducens nerve, go back to the medial aspect, it comes off here. Now, facial nerve is just lateral, cranial nerve 6. Vestibulocochlear, cranial nerve 8, just lateral to the last one. Glossopharyngeal, which is number 9, right here. Vagus nerve comes off right here. Accessory nerve here. And then the hypoglossal nerve comes off right here. The olfactory nerve is strictly for sense of smell, so it's sensory. The optic nerve is strictly sensory as well, and it has to come from the eye, and you get a partial crossing over. Some of the fibers that come from the lateral aspect of the eye stay on the ipsilateral side and go to the lateral geniculate nucleus of the thalamus on your lateral side. Now the ones that strike the eye on the medial aspect, which would be light coming from this direction, the peripheral vision, actually cross over. So they come over here, cross over, and go to the contralateral lateral geniculate body of the thalamus. And then, regardless of which side it comes from, the fibers further go back here into the occipital lobe of the brain, and then the association areas, visual association areas, to be analyzed. Now, this has homeostatic imbalance down to the optic nerve, results in blindness in the eye served by that nerve. So if it's right here, this eye will be blind. But if it's beyond the chiasma here, you'll have partial vision in each eye. Okay, cranial nerve 3, oculomotor nerve, and it does several things. It innervates the somatic fibers to 6 extrinsic eye muscles, so it moves it up, down, sideways. And it also is parasympathetic fibers to the sphincter pupillae, which are the circular muscles of the iris, and they cause the iris to constrict. Now, in oculomotor nerve paralysis, the eye cannot be moved up or down or inward at rest. It rotates laterally. And you also will have droopy eyelid, and the person's eye will be able to constrict. So they may have a long-term dilated pupil. Okay, trochlear nerve goes to right here through the trochlea, right here to the somatic fibers and proprioceptive fibers from the superior oblique muscle. And if you get trauma to or paralysis of the trochlear nerve, you're going to get double vision and inability to rotate the eye inferiorolaterally. Okay, a much more complex nerve here is your geminal nerve. It branches off into three parts, as you can see. The ophthalmic division, there's this part of the face. The maxillary division, this part of the face. And then the mandibular, the mandibular area. And the trigeminal nerve has mostly sensory fibers. And I think I mentioned the mental foramen at some point, right here. See, the mental foramen and the mental nerve. Okay, it's mostly sensory fibers. And so if you have neuralgia of the trigeminal nerve, causes excruciating pain. If just even the wind blows, it's going to cause the face to hurt severely, and it can be very difficult to treat. Abducens nerve is right here. It goes to the lateral rectus muscle. And abducens paralysis, the eye cannot be moved laterally, and so the eyeball rotates medially. This is internal strabismus. Some people would call that cross-eyed. Of course, it could be just one eye too. Okay, next we have our facial nerve, and we do have mixed nerves with parasympathetic efferents and sensory afferents. So your lacrimal gland, your tear gland, is innervated by the facial nerve. Many of these areas in here are innervated. Some of your salivary glands here, sublingual gland here, and then you also have to the muscles of facial expression through here are innervated by the temporal, zygomatic, buccal, and mandibular and cervical branches of the facial nerve. Now, in a homeostatic imbalance here, facial nerve paralysis is called Bell's palsy, and it can be associated with a virus, shingles. You can get shingles in that, or any other herpes virus can cause this. So you have all the muscles of facial expression are droopy, may have trouble swallowing, lack of saliva produced here. Generally, just one side of the face is totally droopy. These tend to get better. Okay, cranial nerve 8, we have two parts of it. This is all going to be sensory stuff. So the fibers of hearing are going to go through hearing imbalance for the whole thing. And it's going to go, the cochlear division is for hearing, and the vestibular division is going to be for balance. And so here we have the two coming together and going out here. Now, if you have the cochlear nerve receptors are damaged, or the cochlear nerve is damaged, it's often due to lots of loud music like rock and roll, or going to concerts, or playing your headphones too loud. And that can cause nerve deafness, and pretty much nothing you can do about it once you've destroyed it, so try to protect your hearing. And then the vestibular apparatus, if you have a damage to the vestibular aspect of the vestibular cochlear nerve, you have dizziness, involuntary rapid eye movements, loss of balance, nausea, and vomiting. Glossopharyngeal nerve, you can see it's going to your salivary gland here, mandibular salivary gland. I just called that wrong. Parotid salivary gland, I'm sorry. And many aspects of the tongue, swallowing, taste. So if this is damaged, not only are not going to have saliva from this salivary gland here, you're also going to have inability to swallow or taste food. Now, this could be unilateral or bilateral, but swallowing muscles going out can be deadly because you try to swallow, and it goes, instead of down the esophagus, it could go right down the trachea. Okay, the vagus nerve. Vagus comes from the same Latin root as vagrant comes from. It means wanderer, and that's because it wanders all over the place. Innervates lungs and hearts and liver and stomach, and I think that's supposed to be a spleen, kidneys, various guts. And if you have total destruction of both vagus nerves, that's incompatible with life, because you can no longer regulate your basically body systems. You can have one damaged, perhaps survive and do fine. Okay, now the accessory nerves, there is some debate as to whether they should really be called cranial nerves, because they actually begin here in the area beyond the brain, actually here, coming from C1 to C5, but then they come together and go into the skull and then come back out, innervate the sternocleidomastoid and the trapezius muscle. So if you have injury to either the entire nerve or to one of the spinal nerves, the roots that go to that nerve, you can have a homeostatic imbalance so that your head wants to turn toward the side of an injury because paralysis of the sternocleidomastoid, and you can't really shrug your shoulder because the trapezius muscle is not working properly. Hypoglossal nerve, you can see it goes here to the tongue and under the tongue. Homeostatic imbalance to the hypoglossal nerve. Difficulties with speech and swallowing. If both nerves are impaired, the person cannot protrude their tongue. If only one side is affected, the tongue deviates towards the affected side, and the paralyzed side will eventually atrophy. Okay, that's our cranial nerves. Now we have spinal nerves, and they are mixed nerves, part sensory and part motor. There's 31 of them, and they're named according to their point of origin from the spinal cord. 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal nerve. Now here you have your cervical, thoracic, lumbar, sacral, and coccygeal. Okay, now the cervical plexus is formed by ventral rami of the C1 to C4. Innervates skin and muscles of the neck, ear, and back of the head, and most importantly, innervates the diaphragm. If you're cut between C3, C5, or above that, C1 to C5, your phrenic nerve can be paralyzed and you don't get to breathe anymore. Okay, the brachial plexus from the ventral rami of C5 to C8 and T1 can go from C4 to T2, and it gives rise to nerves that innervate the upper limb. So cervical innervates the upper limb, and these branches are divided into roots, trunks, divisions, cords, and they tend to combine and uncombine. Here, roots, you see the root from C4 then combines in with other trunks and such. The trunks are right here. We have 3 major ones showing. And then the posterior division is shown in green, anterior division is shown in yellow, and we'll look at where these join together and what happens to them. Okay, we have here axillary nerve, underarm area, radial nerve over here, ulnar nerve innervates this aspect, medial aspect of the arm, and these 2 fingers here, these medial fingers, the pinky and the adjacent, the ring finger. And if you hit your funny bone, that is your ulnar nerve. And you get that horrible tingly sensation, and it's not very funny, but it's called funny bone, which is not a bone at all, it's a nerve. Median nerve comes along here and goes through, it innervates these 3 fingers, thumb, and these, the middle finger and the pointy finger. And they go through a carpal tunnel. It's basically connective tissue, fascia, that can become inflamed and compressed. And if they do compress that medial nerve, you'll have pain or inability, numbness, inability to use the fingers that go beyond, that are innervated by this median nerve. Basically, something to take home from that: pinky finger, ring finger, you don't have carpal tunnel. If it's the thumb, forefinger, and middle finger that are hurting as well as the wrist, then it could be carpal tunnel disorder. However, it could come from the neck or anywhere in the arm coming down to these. Okay, the lumbar plexus arises from L1 to L4, innervates thigh, abdominal wall, psoas muscle. The femoral nerve comes from this, innervates your quadriceps, the skin of the anterior thigh and the medial surface of the neck of the leg, and then the obturator nerve, which goes through the obturator foramen and innervates adductor muscles. So here we have, you can see this is your obturator nerve. Now, I don't know about the human species, but I know in cattle, difficult labor will often compress that obturator nerve and cause inability to adduct the leg muscles, and therefore they will be lay out and not be able to get up. Okay, your femoral nerve comes through here, and we'll get up closer. You can see femoral nerve here, lateral femoral cutaneous nerve, and your obturator is here. Okay, the sacral plexus serves buttocks, lower limb, pelvic structures, perineal area, and your sciatic nerve, which is the longest and thickest nerve in the body. It innervates the hamstring muscles, adductor, magnus, and most of the muscles of the leg and foot. And it comes from 2 nerves that come together, tibial and common fibular. So you have the beginning of it here. This is the sciatic nerve here. And this is the tibial nerve here. This is a common fibular nerve. Now, if you look at the nerve as we go on up from here, right there, it comes right through. It started up here, but it comes right through the sacroiliac area. And this is basically what the whole idea of chiropractics, as far as your lower back, comes from. The idea is that that sacroiliac joint gets a little bit out of adjustment, out of whack, and they twist and crank. They adjust that joint so that the pressure is taken off the sciatic nerve and it gives instant relief. And it really does, because I've tried it before. It unfortunately comes back. Okay, innervation of the skin is from dermatomes. And these are areas of the skin that are innervated by the cutaneous branch of a single spinal nerve, and all the spinal nerves except C1 participate in dermatomes, but most overlap, so you don't get total numbness from damage to a spinal nerve. But knowing about where these dermatomes are gives a neurologist a great advantage to understand just exactly what is hurting, where the spine may be compressed, causing pain or discomfort. Very odd and interesting things to look at. For instance, lumbar nerve 1 affects this area here, and it's difficult on this small picture to see way up here. Okay, sacral nerve with S2. Yeah, sacral nerve 2. Here, here, down here. So you're going to have numbness here. So if they prick that nerve, you're going to have numbness. Also, on the anterior portion, right there, they're probably not going to get away with pricking that one. Okay, and shingles follows dermatomes. So if you see a person with shingles, you will see the blisters and irritation and pain will follow these dermatomes, and it may come around the same, like if it's T4, it'll be T4 also in the anterior portion. And that's why you see those characteristic lines of lesions, because the old chicken pox they got when they were a kid has laid dormant in those dermatomes for years, and then it comes back when they're stressed. Hilton's law, any nerve, muscle that produces movement in the joint also innervates that joint and the skin over that joint. Okay, reflexes. These are inborn or intrinsic reflexes. Rapid, involuntary, predictable motor response to a stimulus. So you put your hand on something that hurts, you pull it back automatically, no plans, no brain required. However, you can take those intrinsic reflexes and learn and become better at doing things, responding, such as driving skills. You learn when a deer jumps out in front of you. As we know, all deer want to jump out in front of you, especially if you have a new car. You learn to visualize that deer and put on the brakes just pretty much instantly because you have learned a reflex response. Okay, components of a reflex arc. You have to have a receptor, which is the site of the stimulus action. Sensory neuron, which transmits the afferent impulses to the central nervous system. Integration center. This is where the decisions are made. This is a nerve that makes the decisions. Maybe one synapse or many synapses within the central nervous system. Motor neuron that sends impulses from the integration center to the effector organ. And the effector is the muscle or gland that responds to that reflex stimuli. Okay, here is a pin stuck. That was your stimulus. The stimuli sends an action potential along the sensory nerve. Then you have the interneuron. You have a synapse here with the interneuron that makes a decision. This has got to be the dorsal side of the spinal cord because sensory always comes in the dorsal aspect of the spinal cord. And this has got to be ventral because motor comes from the ventral aspect. Goes out to the effector. You pull your arm back. Simple withdrawal reflex. Okay, now the patellar or knee jerk reflex is a simple stretch reflex. Someone taps your patella, and when they do so, it stretches this quadriceps just a bit, stimulates muscle spindle fibers here that actually are sensors. And so it knows it's been tapped, and it will send two signals. One signal here goes to the sensory centers here in the spinal cord that will go and cause, and then it's one sensory signal. sensory, and then your interneuron sends two signals. One to cause the quadriceps to flex, to tighten and pull this leg up, and then one that causes your hamstrings to relax. So this is an excitatory stimulus. This is an inhibitory stimulus. So if this muscle shortens, this muscle relaxes. Otherwise, you couldn't kick your foot up in response to that. And that reflex is not there just to entertain people tapping their knee. It's there so that when you're standing up, your body, your spinal cord senses little stretches in your legs that you're a little off balance, not standing just right. And you can stand up at attention or stand still for quite a long time without having to think about it. Okay. These are the same thing. Okay, now the crossed extensor reflex is a pretty cool reflex, and it causes two things: withdrawal of the threatened body part, and starts with a painful stimulus. But we have both, it's both ipsilateral and polysynaptic, and I'll show you what that means. Okay, extensor reflex, I'll just show you the picture. Here we have somebody grabs someone's arm, and the sensation goes up here into the spinal cord, and we have, on the ipsilateral side, we have stimulus, excitatory stimulus coming down here to the biceps that's going to pull and flex that muscle up. At the same time, we have inhibitory reflex going up, or stimuli coming down here to the triceps to allow that arm to pull back. So you've got part A out of the thing, but when you jerk your arm back and somebody's pulling on you, you may fall. So at the same time, you're going to have a contralateral reaction. And what that's going to do is you're going to have a stimulus that goes down here, down here, down here, and your extensor muscles are going to be stimulated. And at the same time up here, your flexor muscles are going to be relaxed. So you pull your arm back and you push the other one out and extend. And in doing so, it gives you something to land on or keeps you from falling. Now, this is an interesting reflex because it's strictly spinal, no brain required, but the brain moderates it. So you have a nice, smooth, normal reflex. If you have severe brain damage, you're not going to get a normal response here. You're going to get excessive response on this, on the withdrawal reflex, as well as on any of these reflexes. So that in fact, when you pull this arm back, it's going to jerk, and this one is going to extend and jerk. And this is one reason why some people who have family members that are actually brain dead are so convinced that they're not, because the spinal cord is still running fine, and they have a great, in fact, they have a hyperreflexia, so that the pull back here on this arm, the flexion of this arm is going to be extreme and maybe shaky. The extension of this arm is going to be extreme and shaky. And this can help one determine whether the injury is spinal. If it was spinal cord, you would get no reaction. If the spinal cord were severed right in here, there would be no reflex at all. Whereas if you have brain damage, upper motor neuron damage, you're going to have hyperreflexia. So no reflex at all, think spinal cord. Hyperreflexia, think brain. Upper motor neuron, brain, hyperreflexia. Lower motor neuron, with spinal cord, it's damaged, think no reflexes. Okay, that's it for now.